we'll go ahead with the bout number 3. For that, I would like to invite Dr. Alap Patel, Dr. Dinesh Raj, and Dr. Amit Chaudhary as chairpersons. And the moderator will be Gyanendra Singh, Dr. Mustafa Rangwala, and Dr. Anand Patel.
And Dr. Sanket Saraiya as the chairperson.
And Dr. Sanket Saraiya.
Okay. Yeah, over to Dr. Alap, Dr. Sanket, and Dr. Amit to introduce our speakers.
Dr. Abhishek Tripathi is working as an interventional cardiologist at Zydus Hospital Ahmedabad. He has done his MBBS in 2002 from GSV Medical College Kanpur and done MD from BG Medical College Ahmedabad in 2007. He has done his DNB cardiology from Batra Hospital and Medical Research Institute, New Delhi. And presently, he is associated as consultant cardiologist at Narayana Multi-Specialty Hospital, Ahmedabad. Worked as a junior consultant cardiology at Batra Hospital and Medical Research Center, New Delhi for 1 year. He also had the experience of assistant professor of cardiology at Nizam's Institute of Medical Science, Hyderabad from April 2012 to May 2014. So our next speaker is Dr. Sarath Chandra. Dr. K. Sarath Chandra is one of the most experienced international cardiologists from India. He had completed his DM from PGI Chandigarh in the year 1989. Currently, he is working in Hyderabad. He is one of the early international cardiologists of India and did first device closure of congenital heart disease in Hyderabad and also the first case of Rota in 1994. He has performed thousands of coronary angioplasties and has special interest in the left main intervention. He has performed coronary intervention abroad, even in China and Vietnam in 1998 and 2004 respectively. He was the chairman of the National Intervention Council of India during the year of 2008 and 2009. He was the editor of Indian Heart Journal from 2012 to 2014. He was the president elect in 2017 and president of Cardiology Society of India for the year 2018. Our next speaker is Dr. C.K. Pandey from Mumbai. He is the gold medalist throughout his UG and the PG career. He has done the fellowship in interventional cardiology, FSCC, FSCI, FESC, FCSI, FIA, FISC, and FICC. He has done his electrophysiology from Brisbane, Australia, from 1993 to 1997. He is the recipient of many awards like Fellowship Award in 1995, Olympian Health Award in 1997, Rashtriya Man Seva Puraskar in 1999, and National Prime Time Award in 2016. He has up to 100 publications in various national and international journals, and he has delivered more than 500 lectures in various national and international conferences. He has received the Inspiring Cardiology of India Award by the Economic Times in 2020. Currently, he is the Vice President of Indian Academy of Echocardiography, and currently he is working as the Consultant Cardiology and head of the Department of Cardiology in BG Hinduja National Hospital, Mumbai.
Thank you, Dr. Alap. We would like to request Dr. Abhishek Tripathi to start his topic.
Yeah, thank you. Thank you so much. Thank you so much. Thank you so much, Kamal Bhai, for giving us this opportunity. And the most difficult thing, you have put me against Dr. Sarath Chandra, under whom I was under training in Nizam. So welcome, sir. Good evening. So the topic today, as we all have discussed, the patient profile, 65-year-old diabetic, hypertensive, 66 kg weight has been given very precisely more than 60. Age has been given less than 75 to make it more discussion oriented. There is history of coronary angioplasty to LAD with death 7 months back on Clopidogrel and Aspirin with recurrent mild hematuria, maintained hemoglobin, workup revealed BPH. GFR remains around 60. So the now question is, patient who is already stable with some history of hematuria, bleeding, hemodynamically stable, no significant anemia. Patient on Clopidogrel and Aspirin within 1 year of angioplasty, should we change antiplatelets or what? Should we continue with aspirin clopidogrel or should we change? So my choose would be that why this patient came to follow-up. Was it a regular follow-up? Was there any ischemia, some worsening condition? Anemia was already mentioned, it was not there. So other considerations should be taken into picture. My take would be I would switch from aspirin and ticagrelor combination. I will touch the reason one by one. as we all know, the nascent platelets, reticulated platelets, they are higher in granules, and they have very high reactivity than older platelets, and they are mostly associated with cardiovascular disease and events. If you see in healthy subjects, the number of activated platelets are not, and number of granular platelets are not that high. If the patient becomes unstable, like anstemy, and when progressing towards STEMI, the number of immature platelet fraction, it grows significantly high. Why it is important? Because we have to see which are the molecule available, which works more precisely on immature platelets, granulated platelets. If you see the mechanism of action of ticagrelor versus the thienopyridines, they are irreversible. They bind to ADP P2 white receptor, whereas ticagrelor reversibly binds. So it is free to bind again and again to different ATP P2 white receptors. Not only that, ticagrelor binds to P2 white receptor as well as it inhibits ENT1 transporter. So what does it do? It inhibits the uptake of adenosine and makes it more and more available, which helps in cardioprotection, vasodilatation, further inhibition of platelet aggregation, modulation of inflammation. It also causes dyspnea and improve endothelial function. So we can see ticagrelor doesn't only act to P2 white receptor inhibition, also it causes more and more availability of adenosine. So now if you see, I'll skip. So ticagrelor is the only molecule out of the prasugrel and clopidogrel which is not a prodrug. It doesn't need liver for activation. So it is not dependent on cytochrome P2 C19 system for its activation. And this is why it is important, because in Asian community, we have pleomorphism of the cytochrome P2 C19 enzyme. So because of the pleomorphism, some people are there rapid metabolizer, some are late metabolizer, and some are intermediate metabolizer. And depending on that, the availability of this thienopyridine varies from person to person in Asian community. Whereas ticagrelor largely remains uninhibited because of this cytochrome system. Here you can see, like if you see this thienopyridine versus the BD dose of ticagrelor. Initial binding, like when you have given the dose within 30 minutes, this binding is there in both the groups, thienopyridine as well as in ticagrelor group. In 12 hours time, what happens? That because of this repeat binding, a reversible binding, ticagrelor keeps binding to nascent and new nascent platelets. However, by 12 hours time, the nascent binding of platelets decreases in thienopyridines. And this is the time when ticagrelor is given again. After 24 hours, once the peak effect of the dose is waning off, you can see again the binding of nascent platelets. Once those are uninhibited, that is besides the point. In acute ACS, once the nascent platelets are being generated again and again, the binding remains more complete with ticagrelor compared to thienopyridines. So ticagrelor is superior to prasugrel, as have been seen in pharmacokinetic data, that compared to prasugrel, if you see the non-reticulated site platelets, both are equally effective. But if you see nascent platelets, granulated platelets, ticagrelor is far more effective than prasugrel. However, these are the pharmacokinetic data. Now, once daily dose is insufficient in patients with high platelet activity. Here you see the prasugrel is being given daily dose. At the late part of the prasugrel dose, the activity of platelet activity again goes high. Whereas ticagrelor, even during late stage also, the effect of platelet activation is low. So this is to summarize, like the reversible binding is there with ticagrelor, not with thienopyridines, and it is active without metabolism, and the mean half-life remains around 7 hours for the active drug because there is no prodrug. So what is the confidence factor like ticagrelor? When we are using ticagrelor, we are all using it without too much consideration. When we are using prasugrel, we always keep counting age less than 70, weight more than 60. There is no history of any stroke, trauma, or ICH anywhere in the past, even any kind of ischemic stroke also. While using ticagrelor, we don't see much. Even if patient is thrombolized just 4 hours back, we are using. Even if patient has been loaded with clopidogrel, we are using. So there is not much consideration, not much fear factor around ticagrelor as much as it is around prasugrel. So ticagrelor is a broad applicable antiplatelet, which can be used in ACS patient across the range, whether the patient is being managed medically or intervention, angiography, diagnosis, angiography has been done or not, his line of management has been decided or not. We can use ticagrelor invariably. In patients with moderate to high risk ACS patients, where the risk of ischemia is high, again, it can be used irrespective of the line of management. However, prasugrel is recommended only when the PCI has been decided, and the PCI only in the PCI setting, not in the medical management line. Now, again, ticagrelor shows decreased CV mortality versus clopidogrel in plateau. However, prasugrel has not demonstrated decreased CV mortality. The MI risk was low in TRI-20 38 and trials ACS, but the CV mortality was not significantly lower. Again, the another benefit, ticagrelor can be used beyond 12 months, like in Pegasus TB54, it has been seen. It can be used in 60 mg BID up to 36-month time also. Prasugrel has to be used for 1 year. The data is for 1 year only. And ticagrelor shows less stent thrombosis compared to clopidogrel in RCT as well as real world evidence also. So, as we have mentioned, ticagrelor can be used in wide range of ACS patients, irrespective of their line of management. However, in prasugrel, mostly in tritontemia 38, if you see, it was being given in cath lab after angiography the diagnosis was known that if the patient doesn't need bypass, it was being given. And the contraindication, as I mentioned, we have to see the patient age. If it is more than 75, you can't use. If the weight is less than 60, ideally should not be used. In India, we are using 5 mg also sometimes. And contraindicated, if there is any previous history of even ischemic stroke is there, it is contraindicated. So we have to see all these things. But in ticagrelor, you need not to go for these. So this is just to summarize. Like if patient is having ACS, there is no contraindication for ticagrelor, please use it. In prasugrel, you have to see the history of TI, stroke, need for CABG, coronary anatomy, medical management versus non-invasive management, weight, age, and all these things, pre-treatment with clopidogrel, prior thrombolized or not. So all these things you have to take into consideration before loading the patient with prasugrel. So it makes life easy with ticagrelor compared to prasugrel when you are starting also while managing in long term also. ACS guidelines, it has class 1 recommendation for patients to use ticagrelor in ACS patients with moderate to high risk of ischemic events. So in all patients with moderate to high risk of ischemia, it can be used. Ticagrelor can be used. Prasugrel is used only when the patient has been planned for PCI or in patient previous ACS who are not thrombolized, being managed medically and now coming up for angioplasty. Clopidogrel is used only once the ticagrelor or prasugrel cannot be used. Similarly, the latest ESC guideline, it mentions ticagrelor is preferred P2Y2 inhibitor irrespective of management study. As I mentioned, like if ACS patient is there, whether medical management, invasive, delayed, pharmaco-invasive, anywhere we can use ticagrelor. Prasugrel, once the PCI is intended, then prasugrel can be used. That time prasugrel, ticagrelor both can be used. But prasugrel, we have to make certain that it has been studied mostly in the PCI setting. So recommendations are there for the PCI setting only. And for other things like the DAPT duration for clopidogrel can be used beyond 12 months. Ticagrelor can be used beyond 12 months up to 36 months. However, with prasugrel, there's no data to use beyond 12 months. So if you see the benefits of compared to clopidogrel in plateau, the ticagrelor has been shown to decrease both composite endpoint of CV death and MI, as well as CV death individually and MI individually. However, in tritontemia 38, the composite endpoint was decreased out of only reduction in MI. There was no reduction in CV death. The MI was significantly decreased compared to clopidogrel. So the non-CABG related major bleeding was high in both ticagrelor as well as prasugrel compared to clopidogrel. However, CABG related major bleeding was high with prasugrel. Fetal overall bleeding was high with prasugrel. It was not high with ticagrelor. Intracranial bleeding was not studied, not recorded in patients with prasugrel, so it cannot be compared here with ticagrelor. So it is approved for long-term, more than 12-month protection, as we just mentioned in Pegasus TB54 study. Now, coming to stent thrombosis, in plateau invasive, it was seen that in stent thrombosis, there was significant 36% reduction was seen in stent thrombosis compared to clopidogrel. Definite stent thrombosis, significant reduction, probable or definite, significant reduction, and in all possible, probable, definite, there was significant reduction was observed over 1 year period compared to clopidogrel. So the timing of stent thrombosis, like even till for the first 30 days, for first 1 month, in subacute stent thrombosis, there was 40% relative risk reduction was there. Up to 30 to 360 days, like late stent thrombosis also 52% risk reduction was there. So this is the reason where we will consider, even if the patient is stable, if the patient is less than 1 year of angioplasty, patient is clopidogrel, you may still consider shifting the patient from clopidogrel to ticagrelor. Zero stent thrombosis was observed in patients with ticagrelor, while in clopidogrel, around 9% stent thrombosis was observed. This was a small study. Now coming to the bone of contention, the last study, ICER React 5, which pitched ticagrelor against prasugrel, and the prasugrel was shown beneficial as far as the MI reduction was concerned and stent thrombosis was concerned. But if you see this study in detail, you will find that in STEMI patient, both the group were randomized and they were loaded with ticagrelor prasugrel before angiography. However, in STEMI, ticagrelor was given beforehand. However, prasugrel was given after angiography once it was decided that the patient is going for angiography. Now angioplasty. Now
Last 1 minute, sir.
okay, so I'll just finish. So if you see in this study again, there was out of 85 patients, 1.3% they did not receive ticagrelor. However, in prasugrel arm, 13.9% they did not receive prasugrel. So the exclusion rate was much higher in prasugrel group compared to ticagrelor. Finally, also if you see, around 1.1% were excluded from safety analysis. However, in prasugrel, 11.6% were excluded from safety analysis. So when the exclusion criteria is exclusive, number of patients was so big, difference was there. It can skew the entire result of the study. MI, again, we can see MI difference was there. Definite stent thrombosis difference was there. Primary endpoint difference because of these two factors were there, but death from any cause was same. Stroke was same in both the groups. And the bar major bleeding 3 to 5 was also same in both the groups. There was no major difference. So the limitation, the major limitation of the ISR React 5 was that this was an open label study conducted in 2 countries. However, Plateau was a double-blind placebo-controlled study conducted in 40 countries. There was a disparity between, if you see the endpoints, if you see the major study of prasugrel, like which was Triton TV 38 versus ISR React 3, the ischemic event was 10.7% Triton TV 38. Here it was only 6.9%. However, as far as the ticagrelor is concerned, in Plateau as well as ISR React 3, ISR React 5, in both studies, the ratio, the percentage was same. It was 9.3 versus 10.2%. So somewhere, because of this open label kind of study and the randomization with sealed envelope and the quality of follow-up was also telephonic follow-up mostly, there was the bias cannot be excluded completely. This may be the reason where the ischemic events were probably reported lesser in ISR React 5 for prasugrel compared to ticagrelor. Then again, for safety, normally it is considered the molecule which is potent anti-ischemic effect will have more bleeding. However, if you see here, the significant number of patients were excluded in prasugrel group, 11.6%, compared to only 1.1% in ticagrelor group. Before
you need to wind up.
Yeah. So I think if Sharat Chandra sir in any case going to include this ISR React 5 summary, as we all know, ticagrelor has an ease of using. We can use it in any given number of patients. The number of contraindications are very less. Post-traumatized patient, already loaded with clopidogrel patient, we can use it safely. Irrespective of line of management, we can use in these patients. It decreases CV mortality, MI, as well as stent thrombosis compared to clopidogrel. So in my patient, in my choice, I will switch this patient from aspirin clopidogrel to aspirin ticagrelor. Thank you so much.
Thank you, Dr. Abhishek. Dr. Sarat Chandra, please go ahead with your presentation.
Yeah, thank you. Thanks, Kamal Sharma, for giving me this opportunity. Abhishek, my old friend at Nizam's Institute, I must say you've done a very good job in this with regard to this subject. Now let me share my screen. All right. You know, the case details that were given to me are slightly different from what have been given to Dr. Abhishek. I have been asked to speak in favor of prasugrel in this particular situation. So let us see what exactly are the case details given. Okay, right. Here you have a 65-year-old diabetic hypertensive who presented with NSTEMI. Now, when you say a diabetic hypertensive, you are straight away saying it is a high-risk patient. His weight is 66 kilos, which is not an issue with prasugrel or with any of the other drugs. He had past history of coronary angioplasty to ostial LAD, which is a very important location, a rather dangerous location of the stent, which has been implanted in the past. The DES was put in the ostial LAD 3 years back, and he has been on clopidogrel and aspirin all these days. And now he presented with NSTEMI, which means that there is some kind of a resistance to aspirin and clopidogrel. This itself is a very high-risk feature, as we all know very well. He gave history of 2 episodes of bleeding in stool, which is stated to be due to piles, but his hemoglobin has always been normal. Now, what is the importance of that? Now, we cannot really say what is the cause of the bleeding. We don't have more details. Obviously, this patient has to undergo upper GI endoscopy and later a lower GI endoscopy if there is a need. And did he have black colored stools or did he have fresh blood? Depending on that, you can take a call on which investigation you would do first. So, but at the same time, the hemoglobin has always been normal, which indicates that probably the bleeding which the patient had in the past has not been probably a major bleeding. And his eGFR is 60 ml per minute, which indicates that it is a fairly acceptable renal function. And we know between these three drugs, there is no issue in relation to kidney function when it comes to usage of any of these three drugs. In fact, with ticagrelor, it is said that if the patients had normal renal function, they did not show benefit with ticagrelor over clopidogrel as given in the old Plateau trial to which Abhishek was referring. So the question is, which P2Y12 inhibitor would be used in this patient? Okay, now let me show you a comparing table between the 4 P2Y12 inhibitors which are available in our market today. The clopidogrel, prasugrel, ticagrelor, and cangrelor, the last one to join the bandwagon. The clopidogrel and prasugrel are irreversibly binding agents, while ticagrelor and cangrelor are reversible. Clopidogrel and prasugrel are prodrugs, while the other two are not. The half-life is about 7 hours with prasugrel, and with ticagrelor it is 8 to 12 hours. Type of binding is competitive with clopidogrel and prasugrel, while it is non-competitive with ticagrelor. The route of administration is oral for most of these drugs except cangrelor. And we know clopidogrel can be given once daily or even twice daily. Prasugrel is almost always given once a day. Ticagrelor is always given twice a day. Now, onset of action is rather delayed with clopidogrel of 2 to 8 hours. On the other hand, with prasugrel and ticagrelor, it can start as early as 30 minutes, and with cangrelor within 2 minutes. Now, if you want to compare prasugrel to clopidogrel, the study one has to look at is the Triton-TIMI-38. This is a fairly old trial, but it is a very modern trial in the sense it is a very properly done trial. It is more than 10 years or 15 years old now. And let us recollect the data of Triton-TIMI-38. This is published in 2007, prasugrel versus clopidogrel in patients with ACS. This patient of ours is a case of ACS. And it randomized 13,000 plus patients, 6,000 to prasugrel and 6,000 to clopidogrel. And they were followed for 6 to 15 months. And the primary endpoint is death from CV causes, non-fatal MI, non-fatal stroke. Safety endpoint is major bleeding. Now, the results showed that the primary endpoint, which is a combination of CV death, MI, and stroke, is clearly in favor of prasugrel. 12.1 percentage points with clopidogrel and 9.9 percentage points with prasugrel. And the primary efficacy endpoint is what I just mentioned. Okay, now, if you look at stent thrombosis, there is a huge benefit in relation to stent thrombosis when it comes to usage of prasugrel. Significant reduction in the prasugrel group in the rate of stent thrombosis. It is 2.4% with prasugrel and 1.1% with 2.4% with clopidogrel and 1.1% with prasugrel, which is statistically significant. Now, look at this balance of efficacy to safety. And here again, prasugrel scores over clopidogrel. Major bleeding was observed in 2.4% of patients receiving prasugrel and 1.8% of patients receiving clopidogrel. Now, you need to look at the diabetic subgroup results in relation to Triton-TIMI-38 because our patient is a diabetic patient. And you can see here, the prasugrel reduced the rate of primary endpoint by a much greater percentage point. It is almost 5 percentage points less compared to clopidogrel. So you have a diabetic patient, prasugrel clearly scores over clopidogrel when it comes to treating the patient by percutaneous means. That's what most of us do when the patient presents with an STEMI. It is 17% versus 12.2%. When the whole group is taken, of course, there is a benefit. But when you take this diabetic subgroup, the benefit is even greater and very glaring. Now, if you see the TIMI major non-CABG bleeds, there is no significant difference between clopidogrel and prasugrel. So prasugrel therapy in patients with ACS with scheduled PCI shows that significantly reduced rates of ischemic events, including stent thrombosis, increased risk of major bleeding, including fatal bleeding. But the overall mortality did not differ significantly between the two groups. Benefit was much more significant in diabetic patients, particularly if they are younger and male patients. Now, when we want to compare it with ticagrelor, obviously you need to look at the data of ISAR React 5. Unfortunately, all these years we have been taught, and most of us interventional cardiologists believed that prasugrel is a more dangerous drug than ticagrelor. Rather, ticagrelor is a more safe drug. The push given by the marketing forces that be was much greater with ticagrelor, and therefore ticagrelor has become very popular all over the world, including India. And Indian doctors, as you all know, they play for safety more than anything, and that's how ticagrelor has been very popular in India. But the data from ISAR-REACT-5 is what you should really look at it. There are limitations of ISAR-REACT-5 as exemplified earlier by Abhishek, but let us look at the positive points of this particular trial. Intracoronary stenting and antithrombotic regimen, rapid early action of coronary treatment fact. Now, earlier we were always comparing plateau data with Triton data. This is not correct. You do not know really what is the type of patients that have been randomized, and comparing the data of one trial to another trial just because they have been compared to clopidogrel is not correct. The correct thing to do is to compare a trial, is to look at the data of a trial where ticagrelor is compared to prasugrel when their patients are randomized on one-to-one basis. And you can see here that this is an investigator-initiated, multi-center randomized clinical trial was conducted to compare the efficacy and safety of ticagrelor and prasugrel again in ACS patients, which is very relevant to the patient data that is given to us. Ticagrelor versus prasugrel in patients with acute coronary syndrome, published in 2019, very recent trial. Now you can see here that this is not a small trial. Once again, there were nearly 4,000 patients who were randomized in this, 2,000 to prasugrel arm and 2,000 to ticagrelor arm. And you can see here, prasugrel has scored over ticagrelor. The primary endpoint, once again, is a composite of death, MI, stroke, and safety endpoint being bleeding. And you can see here that cumulative incidence of safety endpoint, once again, there is not much difference. Prasugrel has nominal greater advantage over ticagrelor, but this is not statistically significant. The incidence of primary endpoint was significantly lower among those who received prasugrel than among those who received ticagrelor. Incidence of major bleeding was not significantly different between the two groups. Now, if you look at this data, the cumulative incidence of primary endpoint at 1 year, 9.3% versus 6.9% with prasugrel. A primary endpoint event occurred in 184 of 2012 patients who were randomized to ticagrelor and 137 of the patients who were randomized to prasugrel. And the cumulative incidence of safety endpoint at 1 year, 5.4% versus 4.8%. Now, to further look at the data of ISAR-REACT-5, the primary endpoint, as I said, is 9.3 with ticagrelor, 6.9 with prasugrel.
Last 1 minute, please, sir.
I take a much lesser time. Just give me a couple of minutes more. I'm almost close to completion. Death is lower with prasugrel. MI is lower with prasugrel. Stroke is nominally lower with prasugrel. Definite or probable stent thrombosis, once again, is lower. And the combined endpoint is clearly in favor of prasugrel. Bleeding, contrary to what many of us believed that it will be more likely to be with prasugrel, was not the case. When you really looked at it, the bleeding events were less with prasugrel compared to ticagrelor. Definite stent thrombosis also was nearly 50% less compared to ticagrelor. Now, among patients who presented with acute coronary syndromes with or without ST elevation, prasugrel was superior to ticagrelor with respect to composite endpoint of death, myocardial infarction, or stroke. Fewer myocardial infarctions in the prasugrel group than in the ticagrelor group. This is not just the data of ISAR-REACT. You can see the data from some more slides, which I am going to show you. This is the regular trend that the chances of myocardial infarction are less in the prasugrel group than in the ticagrelor group. This is a sub-study of STEMI patients in the ISAR-REACT. ISAR-REACT included a wide variety of patients of ACS, but when you look at the STEMI subset of ISAR-REACT, ticagrelor was associated with higher incidence of myocardial infarction. Now, prasugrel is a preferred antiplatelet agent in primary PCI STEMI, diabetes mellitus with ACS, recurrent ACS while on clopidogrel, at risk for stent thrombosis. Now, out of these 4 criteria, 3 are easily correct in relation to our patient. He's a diabetic, He developed ACS while on clopidogrel and aspirin, and because the stent was located at a very important point, he may be running a risk of stent thrombosis or a severe in-stent restenosis, which may be making him more prone for events. So our patient clearly is a case for prasugrel than ticagrelor. I'm coming to the last couple of slides. This is a study from Leeds, UK. It's a real-world study which compared a huge number of patients who were treated with clopidogrel, prasugrel, and ticagrelor, and prasugrel is associated with a lower 30-day mortality compared to clopidogrel and ticagrelor. Now, this is another data from about this is a meta-analysis of 70,000 patients, of whom 40,000 were on either ticagrelor or prasugrel, and about 36,000 were on clopidogrel. And what did it show? It showed that prasugrel shows greater reduction of CV mortality by 15% and 18% compared to clopidogrel and ticagrelor respectively. Prasugrel was more beneficial in reducing MI, MACE, and definite or probable stent thrombosis than ticagrelor and clopidogrel. 31% greater reduction in stent thrombosis than ticagrelor. I think since the time is nearly over, I will close my talk, and if any questions are there, we can discuss. Thank you very much.
Thank you so much, sir. We would like to request Dr. C.K. Pandey. Everybody, all speakers are kindly requested to remain in time because we will have international speaker also. They will be having problems otherwise. Please, you kindly understand, please. Thank you.
Yeah, I think we have heard two stalwarts here before me, and I hope that I make some my simplistic slides will make us some bit of sense in these slides which I'm going to show. So I think the case scenario, correct me, Kamal, if I'm wrong, 65-year-old diabetic, hypertensive, weight was 66 kg, eGFR was 60. He had a PCI with DS 7 months ago. I think Dr. Sarath Chandra was given some different case scenario, I'm not so sure. Was on DAPT with aspirin and clopidogrel and presents with mild hematuria. He's investigated and the cause is found to be BPH. That is what was my case scenario. Am I correct?
Yeah, that's correct.
Okay, fair enough. So what we don't know, what was the clinical setting? Was that ACS or CCS? The PCI was done with ACS or CCS. And what was the complexity of the PCI? And whether he had single vessel disease or multi-vessel disease. Those are the variables which are blinded to us purposefully by our dear Kamal, Dr. Kamal Sharma. So let me take frequency and prognostic impact of bleeding events in this ADAPT-DES study. 9% bleedings were genital urinary. And in the past 2 decades, the ischemic events because of better and better P2Y12 inhibitors have reduced from 18% to 9%, halved almost. But the bleeding has increased because of more potent P2Y12 inhibitors. DAPT, what are the problems with the DAPT? The problems with the DAPT are higher bleeding, risk of bleeding is continuous and exceeds the ischemic events risk 30 days after the index PCI. Bleeding events increase the risk of MACE further, and any major bleeding increases mortality. So the case in question is not really about aspirin, clopidogrel, or ticagrelor. Is about balancing the risk of bleeding versus the risk of ischemic events, and that is the bottom line. So why bleeding increases mortality? Because major bleeding leads to transfusion. There is prolonged storage of transfusion leads to activation of inflammatory cascade. And of course, because of bleeding, you may land up in seizing or stopping the DAPT for a short duration, exposing the patient to the risk of stent thrombosis. Now, the main question and the fundamental question and the billion-dollar question here is, do we need DAPT beyond 6 months in a patient who had a PCI with a DS? Forget the setting. ACS, CCS doesn't matter. Do we really need that beyond 6 months? Guidelines say whether it is stable coronary artery disease or acute coronary syndrome, if you have a high bleeding risk or a patient who bleeds, 6 months of DAPT is just about adequate. You don't need to give DAPT beyond 6 months. So indeed, choosing the duration of DAPT was an art of medicine where the science did not exist until 5 years ago, until the Stop DAPT trial came. But now we have science, and I will show the science. So when you compare ischemic risk versus bleeding risk, let us say you have done ACS, you have taken during PCI, preloading you have not done, etc., etc. you have done risk stratification, you have done bleeding prevention by depth intensity, PPI, counseling, etc. But the patient yet lands up in bleeding. When the patient lands up in bleeding like our patient has, you have to shorten the depth. So there is no question of continuing the depth in this patient beyond 6 months. You have to de-escalate the depth. So you cannot think of giving aspirin with ticagrelor. No question. That question doesn't arise. What question is, if at all monotherapy, which monotherapy? So, is our patient is at high ischemic risk? So, if you have 2 or more of these factors, he is high ischemic. Our patient has only one factor, that is diabetes. So, he has moderate ischemic risk. Do we know the complexity of our PCI in this patient? No, we don't know. Whether there were 3 stents implanted, 2 lesions treated, total length was more than 60, we don't know that. Even assuming it was there. Look at this slide. Beyond 30 days, the risk of ischemic events geometrically comes down and reaches nadir by around 4 to 6 months. Whereas the bleeding risk remains so. It comes down below 30 days, but remains higher than the ischemic risk beyond 30 days. So the point here is, we are at 6 months after a DAPT in a patient who had no ischemic events in the first 6 months and has landed up in bleeding, which is, although minor, is recurrent. So now, when trials were done, comparing the hypothesis that 3 months was non-inferior to 12 months, succeeded. 3 months non-inferior to 12 months, succeeded. 6 months non-inferior to 12 months, succeeded. On the other side, when you tested a superiority hypothesis, that 24 is superior to 6 months, failed. 12 months superior to 12 months, failed. 30 months superior to 12 months, there was a lot of problem in this trial. We all know that TAP trial. And then 36 months superior to 12 months, failed. So in this, the TOPIC trial, replacing P2Y12 inhibitor with Clopidogrel 1 month after PCI in an unselected group of patients, unselected, mind you, ladies and gentlemen, without considering the complexity of the index PCI, without knowing what kind of ACS, trop positive, trop negative. After 1 month, when the patient is 1 month event free, shifting the patient to Clopidogrel from a more potent P2Y12 inhibitor reduces bleeding without any additional ischemic event risk. This trial opened the Pandora's box, and then trial after trial. Look at this. Telos AMI released in 2021 ACC, ticagrelor versus Clopidogrel in stabilized patients with AMI. So patients remain stable for 30 days, shifted to aspirin Clopidogrel. What happened? The bleeding risk came down. The cumulative incidence of composite endpoint of death, MI, stroke came down. So the conclusions was, in AMI patients, no adverse events after de-escalation. Stop DAP trial showed among patients undergoing PCI, 1 month of DAP followed by Clopidogrel monotherapy compared with 12 months of DAP with aspirin and Clopidogrel resulted in significant low risk of composite cardiovascular and bleeding events. Mind you, these were not the patients who bled. These were the patients who were otherwise stable. Irrespectively, they were shifted to Clopidogrel monotherapy. And here, there is a patient in my plate who is bleeding, recurrent, although minor bleeding, hemoglobin is maintained, and the cause is BPH, not a sinister cause. Host exam trial, aspirin versus Clopidogrel for chronic maintenance therapies. What happened here? The aspirin had higher event rates, bleeding-wise, and higher event rates, ischemic-wise. Now, Dr. Tripathi might come and say, why not ticagrelor monotherapy? Let me compare Twilight. Look at the Twilight bleeding risk. 7.1% Tica versus aspirin and 4% Tica alone. Whereas Clopidogrel alone, the bleeding risk was 3.7%. I agree that these were high-risk patients, much higher-risk patients than the Telos AMI trial. However, the conclusion was Clopidogrel monotherapy as compared to aspirin monotherapy significantly reduced the risk of composite all-cause death, non-fatal MI, stroke, and readmission also due to ACS and BAG type 3 bleeding. So please remember, don't dump Clopidogrel yet. Don't dump Clopidogrel yet. You can escalate, you can measure your bleeding risk versus ischemic risk by this very simple flowchart in your clinic or in your cath lab. what I will do in this patient. If the setting was of ACS and a very complex PCI has been done, like left main or LAD-D1 bifurcation with decay crush, etc., I would probably continue this DAPT, which is going on, aspirin and clopidogrel. There is no need to escalate the P2Y12 inhibitor here, because 6 months the patient had no ischemic event, no stent thrombosis. And I also know the cause of bleeding is a minor bleeding, and the cause is not sinister like CA or GI cancer or something like that. Otherwise, I will shift to clopidogrel monotherapy. That will be my take. So my final slide is, we know we have versatile tika here. We know we have aggressive clopidogrel here, prasugrel here, but the king will still remain the king, and that is clopidogrel. Thank you very much.
We would like to keep this forum for open discussion.
Yeah, so the scenario had changed. I don't know, somewhere, Dr. Sharat Chandra. But anyway, the important thing was to understand two aspects. One was single antiplatelet versus dual antiplatelet. Can we have the slides, Neelam? So beyond what time we can stick to one? And then if we are sticking to one, which one of the three? So Dr. Sharat Chandra, your take, if it was supposed to be, say, only prasugrel, why not? Please unmute yourself, sir. So you're muted. Dr. Sharat Chandra?
Okay, I'm here. Now, what is the question? Did you say, can you just repeat the question?
Yeah, if it was not for a dual antiplatelet, just a single antiplatelet, why not prasugrel?
Well, we don't have data with single antiplatelet therapy with prasugrel, so I cannot really comment on that. I'm very impressed with ticagrelor monotherapy when I looked at the data of Twilight, and one should not forget there is another trial called the TICO trial, which is very, very similar to Twilight trial. And there also, there was extremely encouraging data in relation to ticagrelor monotherapy. And TICO trial was done in ACS patients. So, the days of, using long-term dual antiplatelet therapy are more or less over. We all know today that it is the combination with aspirin that actually increases the bleeding risk, particularly the upper GI bleeds. So this is one point I would like to say, that use after 3 months, as shown in Twilight and TICO, of a ticagrelor monotherapy, probably with prasugrel. If somebody does a trial, then we can probably support it. Second point, I'm very impressed with in relation to this dual antiplatelet therapy is, and bleeding risk is, that it is not enough to say that if your patient has a bleeding problem, I will cut down on one of the drugs or both the drugs or whatever. It is also important to look at the source of the bleeding. There is a very good data from Poland where they had 6,000 patients of genitourinary bleeding, and they found that most patients had some cause for bleeding. This is the case with my own experience also. So I would say, instead of coming down on life-saving, important, effective antiplatelet therapy, you also look at the source of bleeding, and probably by treating it, you can reduce the chances of bleeding in future. It is a combination of antiplatelet therapy plus the source of bleeding that is responsible. It is easy to stop the antiplatelet therapy and then reduce the chance of bleeding, but then lurking very closely around is a thrombotic event. So all these patients who develop bleeding while on antiplatelet therapy, they should be investigated thoroughly.
I will also completely agree with Sharat Chandra sir, that if at any point monotherapy comes, probably ticagrelor will stand better than all the available monotherapy. And bleeding source definitely should be well vetted. Like we most commonly see the gum bleeding and all, and it is not because of the antiplatelet, it is because of the poor gum hygiene and then lower oral hygiene. That is mostly the source. One question to Pense sir, like he said, he will prefer to go with clopidogrel monotherapy rather than aspirin and anything else. So we know regarding the resistance of clopidogrel in Indian community, and it's a good amount. This the percentage, if you see, varies from almost 40 to 20% across India. So are you still content with starting clopidogrel monotherapy after 6 months versus aspirin monotherapy after 6 months versus ticagrelor monotherapy after 6 months?
Yeah, that's a good question, Dr. Tripathi. I agree with you. I was given to support clopidogrel. Definitely, I presented some data. But in Telos AMI and the Hathway trial, both these trials have shown unselected group of patients being de-escalated to clopidogrel alone after 6 months. See, most important factor here is after 6 months. So 6 months, patient didn't have any ischemic event, and by 6 months, majority of the newer generation DES, they get endothelized, and ischemic events are very, very minimal after 6 months of therapy. So that is one point. And second point is the in vitro resistance. Our own paper in 2009 first and 2016 in quite two respected journals showed that there is very poor correlation between the laboratory resistance versus the clinical resistance to clopidogrel. That is my biggest problem so far. So many patients show laboratory, they are not responding to clopidogrel, clinically they respond, and the other way around. So it is very difficult to choose a drug that way. I think we should go by randomized control trial data here. And I would be very happy for a ticagrelor monotherapy, but I will not be happy to add another P2Y12 inhibitor to aspirin beyond 6 months in this patient at any cost. And if the patient's clopidogrel aspirin has worked for 6 months, why not clopidogrel alone will work after 6 months? That will be my take.
So the two quick points, sir. Two quick points. Like we mentioned that after 6 months, all the new generation DES open to both Ponce sir and Sharat Chandra sir. So like we mentioned, after 6 months, the industrialization is good, and we don't need 6 months beyond 6 months. But we know that there are the newly not that old. We have coined the word very late stent thrombosis. There's stent thrombosis beyond 1 year also. We are seeing in our practice also. Number one point. This one side we are looking for a lesser and lesser duration of antiplatelets. Second side, we are not even sure how long it does really take in different scenario of patient. Number one. Number two, Twilight and Tico, they were all for the Western population. They were not for Indian population. Number three, we have really observed that after coming this ticagrelor and prasugrel in picture, this rate of MACE, re-MI, rehospitalization, and this unplanned hospitalization has really gone down. So these molecules are definitely helping us. If you see the real world practice, real world evidence. So I think everything should be taken into consideration. Real world evidence as well as the randomized control data.
I think if you ask majority of the interventionalists, the fulcrum, I mean the majority of the opinion will turn in this case towards tica monotherapy alone, followed by clopidogrel monotherapy, and followed by aspirin, continuing aspirin clopidogrel irrespective of 75.
No, that's fine. I agree. But I think in a patient, if this scenario was to become 3 months, I would stick to prasu as the alone one. Maybe, won't you or won't you? If it's a mild bleed? Dr. Sharat Chandra? If it's a recent MI and you want to do a single antiplatelet and it's a proximal ostial LAD, the kind of case that you said, and it was not a GI bleed, as Dr. Ponde was trying to point, if choosing one, would you still stick around with prasugrel and take off aspirin if it's acute bleed?
Let me elaborate on this. If you take molecule to molecule, I have no doubt prasugrel is the most powerful agent. We have had our own experience, like what Dr. Ponde said. A long time back at Nizam's, we did in vitro platelet aggregability testing, and prasugrel, you will be surprised to know that platelet aggregability can be as low as 0 or 2% or 4% in most patients. And that happens in a very short time after the administration of the loading dose. So what is important is that we all know that prasugrel is a very powerful agent. Ticagrelor is also equally powerful probably, but if you really look at the data of Triton TIMI 38, the kind of stent thrombosis reduction with prasugrel compared to clopidogrel is very impressive. 35% reduction of stent thrombosis in a diabetic subset. So if you ask me a question that if you have to use only either prasugrel or ticagrelor, I would go in favor of prasugrel if you have to use only one drug. Yeah.
I think for the sake of time, we need to move to the next session. We had a wonderful session. Thank you very much for highlighting. And I think we brought out the important aspect of single antiplatelet, which one to choose, where is the evidence, which patients to understand and believe as the high bleeder risk or low bleeder risk, a mild bleed and a hematuria, a high risk versus not high risk. So that's why we try to balance it out, the case scenario in that one. Thank you very much. Thank you all the speakers, chairperson, and moderators. Thank you. Over to next session.
Thank you so much.